Could I ask our next panel to come up and get ready? To moderate this panel, I'd like to introduce the Associate Director of CHIPTS, Brett Mendenhall.
All right, thank you very much, Kevin. This session will focus on treatment as prevention for mental health providers. First of all, I'd like to reintroduce Cynthia Grossman. Dr. Grossman is the chief of the Secondary HIV Prevention Program in the Division of AIDS Research at the National Institute of Mental Health. Since joining NIMH, her grant portfolio is focused on research to improve the lives of people living with HIV and AIDS, including reducing the risk of transmission. She actively encourages research in the areas of HIV and mental health, stigma, and disclosure. Dr. Grossman received her degree in clinical psychology and completed postdoctoral training at Brown University. Dr. Grossman.
Oh, great, thanks. Thanks, and thanks for sticking with us here on the just before lunch. So I'm going to speak a little bit about the intersection of HIV and mental health and the challenges to prevention, specifically trying to talk about treatment as prevention and test and treat models. I'm going to really briefly talk about the changes in the landscape. Mary Jane already talked about it, and Dr. Fenton alluded to it as well. And it's been an exciting time. I'm going to talk a little bit about test and treat strategies, specifically some of the promise, but also some of the challenges to the test and treat strategy and treatment as prevention strategies. I'm going to speak a bit about mental health diagnosis and the treatment cascade, and I'm going to talk a little bit about that independent of HIV because I don't think that gets discussed a lot, and there are some nice parallels to draw, some frightening parallels to draw between the cascade in HIV treatment, diagnosis and treatment, and the diagnosis and treatment of mental disorders. And then I'm going to put it all together, talking a little bit about research directions, both broadly, and then what NIMH sees as some of our priorities moving forward. So we all know that it's been a very exciting time, and there's a lot of promise, and as Dr. Fenton said, a lot of shiny new objects to look at and to call our attention to. And within that context, really prior to some of these shiny new objects coming on board, we had the sort of gauntlet was thrown with the test and treat strategy here. And the idea being that if we could certainly increase our testing, and with the increase of testing, those people, the majority of people who are identified as HIV positive do decrease their risk behaviors. We could immediately link them to care. We could start them on early and immediate antiretroviral therapy, have them adhere to that, and maintain viral suppression over time. We could drastically reduce HIV transmission. And this is a slide that I completely pilfered from the HPTN and Sten Vermund and Wafa al-Sadr. And when Wafa presents this slide, she really talks about the fact that the details here are really in the arrows and not the boxes, that we know how to test people. We can certainly improve some of those models, but testing works. We have treatments that work, but it's really trying to get people into testing, and it's trying to get those people who are tested positive linked to care and getting them to maintain adherence over a long period of time. Those are really the challenges to the test and treat hypothesis. I like this slide because of its simplicity. This is Michael Mugavero at UAB. And this really, to me, is the sort of test and treat challenge, the cascade from diagnosis through linkage to care, through receipt of antiretroviral therapy, adherence, and then to your desired outcome of viral suppression in this case. And in there, it looks linear, and that's what I like about it. It looks very simple, like we could do this. This is manageable. But if you look at the arrows, some of the bidirectional arrows really highlight the complexity of this approach, because what we need to do is then retain people in care, and those people who fall out of care, re-engage them in care, and that this is a dynamic process that happens over time. And so there's a lot of complexity built into this very simple picture. Another sort of representation here with a bit more data to it and substance to it is Ed Gardner's paper looking at the stages of engagement in HIV care. And really, this is where I think we get some really frightening statistics related to treatment for HIV-positive people in the United States, and also poses the most challenge to treatment as prevention for people in the United States, where you have a pool of people who we think are HIV infected that we can diagnose as, Dr. Fenton said, about 80%, so 20% of people don't know that they're HIV positive. And then we see the decreases, we lose people as we try to link them to care, retain them in care, put them on antiretroviral therapy, till you get to this 19%. And the idea here is that roughly 19% of people living with HIV in the United States have an undetectable viral load. And so we know from 052 studies about the transmission risk here in terms of the dramatic decrease in transmission risk for those people who have an undetectable viral load. And yet 19% of people living with HIV is estimated here have undetectable viral load. Now, embedded in this paper is another sort of modeling paradigm that Dr. Gardner goes into and his colleagues go into, where they take a look and they model, what if we were to decrease some of these numbers and mess with them a little bit and bring them up to 90%. So what if we could get 90% of people in the United States who are living with HIV to know that they had HIV? And then we could get those 90% linked to care, and 90% retained in care, and 90% on antiretroviral therapy. What could we get this 19% number up to? And in his paper, he estimates that we can get that up to 66%. Well, that's great, and that would be a wonderful problem to have, but it does still represent somewhat of a problem in that 34% of people living with HIV would still maintain a detectable viral load. So that's quite a bit of circulating virus depending on what their viral load is at. So it does pose a problem to treatment as prevention when you're looking at the fact that in a cascade such as this, even increasing to really good numbers of 90%, as we go along the cascade, if you're losing 10% of people at each stage, your numbers shrink very quickly when you're looking at that desired outcome of undetectable viral load. So going back to this test and treat or treatment as prevention cascade here, what are some of the factors that are associated with losing people at each of these stages? And we've already heard from the earlier panels about the role of substance use, and so I really want to focus on mental disorders and their impact on each of these stages. And this is some data from Brian Pence and his colleagues looking at the probability, if you had the probability of a mental illness or substance abuse disorder, and those are the high, low, and moderate lines. What is if you have a high probability, for example, of a mental illness or substance abuse disorder, what's the likelihood that you will be able to suppress and maintain, have viral suppression and maintain it over time? And the x-axis is months since ART prescription, or HERT prescription, which is basically their marker of adherence here. So let's just take the first 12 months. If you refill your prescription at 6 months or 12 months, if you have a high or moderate probability of having a mental illness or substance abuse disorder, you are markedly less likely to achieve viral suppression, achieve and maintain viral suppression, than you are if you have a low probability of mental illness or substance abuse disorder. So So it clearly matters, and this is just one example that I pulled of other examples that we could come up with. I just wanted to show you some data here, but of the fact that mental illness and substance abuse disorder matters in terms of achieving and maintaining viral suppression. So that's sort of the picture. Those are people living with HIV, but what does the cascade, and I presented the cascade to you of diagnosis and treatment for HIV, but I wanted to take an independent look at the cascade or a potential data around a cascade for mental disorder diagnosis and treatment. So let me walk you through this slide. I'm going to spend a little bit of time on this slide because I don't think that these data necessarily are presented very often, and I'm going to talk about the challenges to this data that I pulled together from the references that you see below. So if you had 100 people, let's just say 100 people living with mental disorders, about roughly a third of those people will be diagnosed, okay? That's markedly different from the 70% of people living with HIV who are diagnosed. I'm sorry, the 80% of people who are living with HIV that are diagnosed. About a third of those people who are diagnosed will receive treatment. And the good news in mental disorders is that once you receive treatment, you are pretty likely to be retained. So about 80% of people who are treated are retained in care over time. Now, so unlike with the HIV picture, pulling this data together was very difficult. Number one, there's not really good surveillance databases like there is for HIV. So as much as Dr. Fenton talked this morning about the need to improve and bolster the HIV surveillance, especially given some of the health inequities that he sees and adding that data into that surveillance database, we are markedly behind in mental disorders in terms of our ability to track mental disorders, see who it's affecting, and get data on these different points in care over time. Second, the idea of a diagnosis of a mental disorder is challenging. So for any of you who work in mental disorders and diagnosis, are we talking about the Diagnostic Statistical Manual? Are we talking about clinical symptomatology and clinical levels of, for example, major depression? And as you can see in the diagnosed category, and it continues for treated and retained, there are real differences between the type of mental disorder that you have. So depression and bipolar disorder are more likely to be diagnosed, treated, and retained, for example, than PTSD or substance abuse. So you have real challenges there for diagnosis that you don't have in HIV. And then same thing for treatment. We know that we've got good treatments for HIV. In mental disorders, the treatments for HIV in mental disorders, the treatments for the mental disorders are varied and they happen in different locations. So many people for mental disorders do not actually show up to be treated at a specialty clinic. So this treated category is really for people who showed up at mental health specialty care. If we talked about they showed up at any place to receive any kind of mental disorders, then that might go up to 50% of people who are diagnosed are actually treated. So you can see real challenges in trying to understand the picture for mental disorders independent of HIV, and then never mind layering on top of that HIV. So those are all the differences. What I want to focus on now is the commonality between HIV and mental disorders, and that's really in the who falls out of care, who experiences gaps in care, and who falls out of that cascade. And as we've heard from this morning, from Dr. Fenton's talk, so I won't belabor it, and we heard from the talk on substance abuse, those people are that are less likely to have be retained in care and who more likely to have these gaps in care are people who are minority race and ethnicity, who have lower education, lower health literacy, gaps in insurance coverage, poverty, and I include neighborhood violence into this. I include incarceration and its association with poverty, unstable housing, and then certainly those people living with comorbidities. And so the real question here is, it's really those larger, as Dr. Fenton talked about them, social and structural determinants that sit within these arrows that cause people to fall out and will be the challenge for test and treat and for treatment as prevention approaches. And so when we go back to this, that presents a real challenge. So what are we doing sort of at NIH, and what do I think that do we think that the research community could be focused on to help address some of that? And some of the potential research directions include financial incentives and economic strengthening approaches, service integration, and then certainly the health disparities research, looking at, we have some data coming out and have come out on the role of medical mistrust and stigma. And then community level approaches, looking at social networks and community viral load. And in this case, I'm not necessarily presenting specific research questions associated with these, because I sort of sit at a different place, but really it's up to you all, and the charge is really up to you all to kind of come up with what the research questions are relevant to these areas, and to really start to address and to dig in to the social and structural factors that impede people from taking their pill every day, or impede people from getting from that testing site to that care site. We do issue, obviously, program announcements, and I just want to highlight a couple that we have on the street, and ones that we have put out. On the street currently, there are 2 program announcements to call your attention to. One calling for novel interventions, and this is really trying to develop and test novel interventions, and by novel we do mean new targets, both at the individual level but also at some of these structural and social levels. And then the second one is to advance the impact of currently efficacious interventions. So that's calling for dissemination and implementation type science for currently effective interventions, as well as the novel ways to combine effective interventions so that we get the most impact and reach. We've had past RFAs on MSM calling for new interventions for MSM, one that just closed, and we funded several from that round, and the integration of biomedical and behavioral approaches as well. Currently, we have an RFA that directly speaks to those linkages to care and those gaps in terms of retention and care and timely ART initiation, and that has a September 9th deadline. And we also have broad NIMH priorities, and I just will end by saying that we are trying to align our priorities to be consistent with the National HIV/AIDS Strategy, focusing on reduction in health disparities and reduction of HIV incidence, and increasing the quality of and access to HIV care for those living with HIV. And I really can't hit home enough, although this is really the challenge. It's very hard to sort of think this way and to come up with new models to do our science this way, but thinking about combination approaches at the individual level that go beyond the individual level into the neighborhood, into the community, and beyond, and thinking about the integration of these biomedical approaches, such as treatment as prevention, into the behavioral interventions that we know can be effective for people but may not be sufficient to really decrease the transmission rate to where we want it to be. And then finally tackling some of these social determinants of health, these upstream determinants that are really challenging but have really, I think, we are far enough into the epidemic and have done enough work that it's exactly these factors that require our attention, and it's exactly the challenge that lies ahead for us. So I just want to thank you very much, and I look forward to more discussion.
Thank you very much, Dr. Grossman. Next, I'd like to introduce Adam Carrico. Dr. Carrico is an assistant professor at the University of California, San Francisco Center for AIDS Prevention Studies, where he's pursuing a program of research to address the intertwined epidemics of stimulant use in HIV and AIDS. Dr. Carrico's recent research has elucidated the biobehavioral pathways whereby the use of stimulants promotes hastened HIV disease progression, and highlighted the role of emotion regulation as a potential driver of more frequent stimulant use. Dr. Carrico is currently conducting a series of studies in partnership with the Stonewall Project to develop and test innovative interventions for stimulant-using MSM. Dr. Carrico.
Thanks. That was nice of you to read the whole thing, but I don't know how much people really care. So in any event, everyone's talked about HPTN 052 and all the kind of dramatic advances that have come down the pike in the last year. But I want to start out by thanking Mary Jane and the rest of the CHIPS faculty and staff for coordinating this important meeting. This is a really critical dialogue to have at this time and to be talking about how we can develop integrative treatments and combination prevention approaches. So today I'll be speaking mainly about psychiatric risk factors for HIV disease progression and highlighting how cost-effective approaches to implementing expanded access to ART will require that we address these co-occurring psychiatric conditions. Work from our team and others highlights that psychiatric factors impair HIV disease management, resulting in incomplete viral suppression. So if we're really in this to change community viral load, we need to work with populations that have psychiatric comorbidities and provide those adjuvant treatments to help them address their mental health and substance use disorders. So I'll begin with a review of this literature, highlighting some of the controversies that have emerged in the role of psychiatric risk factors in HIV disease progression, and also talk a bit about the mechanistic questions that remain that we've looked at with our data. I'll present the results of two cohort studies. The first is Elise Riley's NIDA shadow cohort. It's a cohort of homeless and marginally housed HIV-positive persons, and that'll be a cross-sectional paper. The second is from the NIMH Healthy Living Project, where we examined the extent to which inconsistent patterns of ART utilization explain the effects of psychiatric risk factors on viral load. And then I'll end with a discussion of the clinical and public health implications, and hopefully get us started on a broader discussion about how to change these things that we've been trying to change for 20 years, and innovative approaches. So, as I mentioned, difficulties with HIV disease management are really a lost opportunity, both to optimize health outcomes and mitigate HIV-related health disparities, but now we know to reduce HIV incidence. And in general, community-recruited cohorts like the WISE and the MAX and Gail Ironson's cohort in Miami demonstrate that prevalent psychiatric comorbidities predict hastened or more rapid HIV disease progression. And interestingly, this literature has found that these effects are observed after you control for adherence to medications. So adherence in this instance is the proportion of missed doses taken. So this is interesting. We have spent a lot of time trying to understand the other biological and behavioral mediators of this effect of psychiatric risk factors. And evidence is strongest for depressive symptoms and stimulant use of cocaine, crack, or methamphetamine. And in contrast, there are some HIV clinic-based cohorts where they find the opposite results, such that psychiatric comorbidities are associated with more persistence, so utilization of ART for longer periods, as well as longevity. And this may be due to the methodology of these studies, which assessed psychiatric risk factors through chart review. So you're confounding treatment and diagnosis of mental health and substance use disorders. So we sought to examine whether and how psychiatric risk factors are associated with hastened disease progression in two cohorts. So as I mentioned, SHADOW is a cohort of homeless and marginally housed HIV-positive persons that was recruited from the community. And in this subsample, we did a cross-sectional study with 227 participants. We selected those that were currently prescribed HART, regimens defined as HART, or those that were not on HART but had a CD4 less than 350. So these are individuals that meet the WHO guidelines for initiating HART but aren't currently taking it. And that was our reference condition in this investigation. And as you can see, the sample was predominantly male but multi-ethnic, and interestingly, over half, or slightly over half, had an undetectable viral load. And in the study, we had a pretty extensive computer-based measure called the Diagnostic Interview Schedule, and it screened for current mental health and substance use disorders. And we have the whole laundry list there, but the main ones that we were interested in were major depression, severe mental illness, which included current manic or hypomanic episodes, and all the alcohol and substance use disorders, including stimulant use disorders. And heart utilization in this study was defined as use of a regimen or utilization of a regimen that had 3 or more medications with an NNRTI, or a ritonavir-boosted PI regimen. And viral load was measured in a separate quarterly visit that was within 90 days of the disassessment, and the median was 22, so relatively close. So as you can see here, this is the significant parameters kind of extracted from a much larger model in the paper. But we found that both structural and psychiatric factors were independently associated with heart utilization. And as you can see, being enrolled in ADAP and any mental health treatment in the past 90 days were associated with markedly elevated odds of utilizing heart. And on the flip side, street homelessness, so having any nights spent on the street in the past 90 days, and a current stimulant use disorder were associated with substantially lower odds of utilizing heart. And then what we did next was looked at viral load among those that were on heart. And we observed that approximately 15% of participants had a current SMI. And most of these were a current manic episode or hypomanic episode. Very few participants had schizophrenia or screened positive for schizophrenia. And among those on heart, current SMI was associated with a dramatically elevated viral load, 6-fold higher. So it's a relatively small sample, but you can see the 22 with the current SMI versus the 125. So interesting results. And I should say that that conflicts with past research that's shown that stimulant users have substantially elevated viral load. And it's often that we don't include these mental health factors, and we may be attributing a lot to drug use when it's actually the mental health variables that are driving the non-adherence. And co-occurring rates of severe mental illness among stimulant users are high, obviously. So just a brief summary of findings from this study. Both structural and psychiatric barriers can compromise HIV treatment success in this population. And decreased odds of heart utilization among stimulant users could reflect a lot of things, and I think we really need to spend some time unpacking that together at some point. It could reflect poor engagement in HIV medical care, or it could be that individuals don't have access to medications. And I don't think we talk enough about the stigma that drug users experience in HIV medical care, but it's substantial. If you were to ask yourself, would you prescribe medications to someone with depression versus stimulant use, you would probably say, I would prefer depression. And we'll present some data in a second that shows you it's actually both that have negative outcomes. So just more evidence, I think, that we need to talk about access and also decreased uptake. People may be less motivated to utilize heart when they're actively using, of course. And so we'll need to identify those barriers, as I mentioned, for stimulant users. And overall, this provides some data that indicate that optimizing health outcomes and boosting the effectiveness of test and treat could happen if we're providing concurrent psychiatric care. So the next study was from the NIMH Healthy Living Project. And this was a randomized controlled trial conducted in 4 US cities. And it included over 3,000 people that were screened. So it was a massive undertaking to enroll 936 HIV-positive persons that either reported engaging in transmission risk behavior or in unprotected sex with a non-primary HIV-positive partner. And using these data, our team hypothesized that depression and stimulant use at least weekly would predict elevated viral load over a 25-month follow-up. And then we also examined the extent to which inconsistent patterns of art utilization mediated or explained these effects. So in terms of measures, briefly, we used the Beck Depression Inventory and extracted the somatic symptoms because those are confounded with HIV disease markers. Weekly stimulant use included cocaine, crack, or methamphetamine at least once a week during the past 3 months. And for art adherence, we use the ACTG, which gets the self-reported proportion of doses taken over the past 3 days. And we aggregated all the data across the 25-month period and got an average percent adherence as a covariate for our analyses. And then we examined 3 different patterns of art utilization. So those that discontinued or stopped taking art at some point during the trial, those that intermittently utilized art, so stopped and restarted at least once. And then we compared those two groups to a reference group that was continuously on art from baseline throughout the 25 months. And then, of course, mean viral load was the average over the 25-month follow-up. So the majority of the 603 participants in this sub-study from HLP were male. The sample was multi-ethnic, and approximately 1/3 were virally suppressed at baseline. And interestingly, there were no effects of the Healthy Living Project intervention on art utilization or viral load in this subsample. And elevated depressive symptoms at baseline were associated with a 39% increase in the odds of discontinuation over follow-up. And weekly stimulant use, on the other hand, was related to a 2.5-fold increase in the odds of intermittent art utilization. So these patterns really match the psychiatric profiles quite well. Depression is characterized by hopelessness and suicidal ideation, and this could largely be viewed as parasuicidal, the discontinuation. And stimulant use is marked by periods of binge and non-use, so people are out on a run for weeks and then coming in, getting on their meds again, and going off when they're binging again. So, I've got my little thing here. This is a very busy slide, but it communicates all the different aspects of the mediation analyses that we conducted. So the first part up here, the total effect for depressive symptoms and weekly stimulant use. This was the degree to which depression and stimulant use predicted elevated viral load after controlling for average self-reported adherence and baseline CD4 cell counts. So consistent with prior work, we found that elevated depressive symptoms were associated with a 50% higher viral load after controlling for adherence. And weekly stimulant use was associated with 137% higher viral load after controlling for the same variables. So next we included the mediators in separate models. And because there were two separate causal pathways emerging, we conducted them separately. The depressive symptoms appeared to be completely mediated by art discontinuation, and weekly stimulant use was explained by intermittent art utilization. So these data provide some compelling evidence that the effects of these psychiatric risk factors are largely behavioral. There are other plausible biological pathways like autonomic nervous system activation, hypothalamic pituitary adrenal axis dysregulation, all these sleep dysregulation. There are tons of things that people have proposed. But I think the answer is much simpler than we would like to admit to ourselves as researchers sometimes. But it has huge implications for intervention development. So in summary, these data highlight the role of inconsistent art utilization and support its prominence as a common pathway for health outcomes and addressing HIV-related health disparities among those with psychiatric comorbidities. And behavioral interventions that we've developed, however, focus extensively on getting people to take more medications when they're on them. Very rarely do we talk about sticking with your medications. Even if you're taking them at a relatively low level, you may be deriving a lot of benefit in viral suppression. And David Bangsberg's work highlights this very well, that there are very different rates of resistance at different levels of adherence for medications. So we really need more interventions that focus on persistence, kind of sticking with it, especially in this era of treatment as prevention. Right? And then, as Cindy mentioned, really identifying those implementation gaps for diagnosis and treatment of co-occurring psychiatric disorders is crucial. In the context of HIV medical care in particular, we have a lot of opportunities to triage people to treatment and to provide treatment on site. So kind of taking a step back, looking at the broader kind of clinical and public health implications, where are we going? What are the implications of this? In terms of expanded art access, interventions are needed to address these psychiatric risk factors because it's cost effective. We don't want to be pushing medications out into the community that are going to be inadequately used or promote the development of resistance. So we need to achieve the greatest possible reductions in community viral load to have a prayer of getting it implemented. And we also need to address the key drivers of HIV-related health disparities. We've talked a lot about the social and other determinants of health like racism, homophobia, and those are very important variables, but they're transferred through psychiatric factors. People become depressed, they begin to use drugs, and so this is on the causal pathway, and we need to view psychiatric treatment as a method of alleviating or mitigating health disparities, at least in part. And then I think it would be worthwhile to provide guidance to providers, both physicians, nurses, everyone who will listen to us, about how to manage psychiatric conditions in the context of HIV medical care. There's no clear guidance right now, and providers are largely going on their own judgment and clinical training, which I'm sure is wonderful, and they're always trying to act in the best interests of their patients, but they're weighing very difficult public health and individual benefits when they're prescribing medications. And these ethical questions need to be addressed by us as a broader community to provide more guidance to individuals as they initiate ART with patients that have psychiatric comorbidities and decide whether or not to maintain people on ART. And then interventions targeting implementation gaps are critical. And I've listed a few options here, but I'd be interested to hear what other people have to say too. NIDA has an SBIRT model, screening, brief intervention, and referral to treatment. And this is ideal for implementation in HIV medical care. We can do brief screening, we can triage people to treatment, provide case management to make sure they get there. It's highly cost effective. And then co-located services could be provided on site. We do this at Ward 86 in San Francisco. And then especially for those with SMI and other kind of debilitating mental health conditions, I think intensive case management is critical to kind of help bring in people from their social network to give them the resources to adhere and manage care and deal with the multiple overlapping burdens that this population experiences. And one thing that we don't talk about enough either is low threshold substance abuse treatment. It's time for us to stop saying that people need to be willing, ready, and able to achieve abstinence to deserve drug abuse treatment. Low threshold and harm reduction-based services can be helpful in engaging populations and moving them along the stages of change to address the harms of their substance use and maybe work towards abstinence if that's their goal. But at least we can target part of it and help them take off some of the more dangerous edges. And then Steve talked a bit about conditional cash transfer, which was all the buzz, and it has all of us contingency management folks very excited because it's something to jump under. But conditional cash transfer and CM are evidence-based behavioral approaches that work. And we need to be implementing those and targeting initiation of psychiatric treatment, adherence to psychiatric meds, reductions in stimulant use, adherence to HIV meds. The list of opportunities for those sorts of interventions are unlimited. Right. So I'd like to end by thanking a list of amazing collaborators that I have at UCSF and around the country that have worked on these studies. I had the benefit of being able to analyze all these data and the luck of not having to collect any of it myself, which is wonderful. And in particular, I'd like to acknowledge Steve Marin, who was one of my postdoc mentors and a great kind of mentor in this area.